Assalamualaikum dan selamat sejahtera to Madam Noor. My name is Sarah Nur Adila Mamazin and my partner is Kartiga Nair AP Vejakumaran. We will present about polycystic ovarian disease, or to be known as PCOS or Pcos.
My name is Kartiga and I will be presenting about etiology, risk factor and pathogenesis. What is polycystic ovarian cyst? It is a condition where ovaries produce abnormal amount of androgen, which is the male sex hormone. Etiology of PCOS. It is unknown, but it involves interaction of hormonal abnormalities resulting in hyperandrogenism, anovulation, and infertility. There are three risk factors involved in PCOS, which is high androgen or insulin level, family history of PCOS, and lifestyle. For first risk factor, high androgen or insulin level, androgen is a hormone that controls male characteristics like body hair growth. High androgen can prevent ovulation during menstrual cycle and contribute to other symptoms of PCOS like body and facial hair growth, acne, and male pattern baldness. High insulin level increase PCOS risk and insulin resistance, a condition that changes the way your body responds to insulin. The second risk factor is family history of PCOS. Hormone imbalance and other genetic factors that influence PCOS can be passed from one generation to another. Lastly, lifestyle. Lifestyle alone doesn't cause PCOS, but it works together with genetic and environmental factors. These include being overweight or obese, having poor eating habits, and living a sedentary lifestyle. Next, I'll be presenting about signs and symptoms of PCOS. It involves irregular period or no period at all, difficulty getting pregnant, excessive hair growth, hirsutism, weight gain, thinning hair or hair loss, oily skin or acne, female infertility, and sleep apnea, condition that causes interrupted breathing during sleep, or better known as snoring. Patients of PCOS have higher risk of developing type 2 diabetes, depression and mood swings, high blood pressure and high cholesterol, sleep apnea, high risk of developing endometrial cancer. Then I'll be presenting about pathogenesis of PCOS. Ovaries produce excessive amount of male hormone androgen, particularly testosterone, by either release of excessive luteinizing hormone by anterior pituitary gland or high level of insulin in blood, hyperinsulinemia, where ovaries are sensitive to this stimulus, or reduced levels of sex hormone binding globulin (SHBG), resulting in increased free androgen. Follicles have developed from primordial follicles, but development has stopped at an early antral stage due to disturbed ovarian function. Follicles may be oriented along ovarian peripheral, appearing as string of pearls on ultrasound examination. Patients with PCOS have higher gonadotropin releasing hormone (GnRH), resulting in an increase in luteinizing hormone (LH) or follicle stimulating hormone (FSH) ratio. Elevated insulin level contribute to or cause abnormalities seen in hypothalamic pituitary ovarian axis that lead to PCOS. Hyperinsulinemia increases GnRH pulse frequency, LH over FSH dominance, increased ovarian androgen production, decreased follicular maturation, and decreased SHBG binding. Adipose tissue possesses aromatase, an enzyme that converts androstenedione to estrone and testosterone to estradiol. Excess adipose tissue in obese patients causes them to have both excess androgen responsible for hirsutism and virilization, and estrogen inhibit FSH via negative feedback. PCOS may be associated with chronic inflammation of ovary, which may induce conformational, endocrinal, and metabolic changes.
Okay, next. Hello, I'm Sarah and I'm about to present my part, which is normal menstrual cycle. Normal menstrual cycle has three components, which is brain, pituitary gland, and ovary. In normal menstrual cycle, the brain makes the hormone GnRH, which is released into a special circulation going to the pituitary gland. The pituitary gland then releases two hormones, FSH and LH, which travel in the bloodstream to the ovary, causing the ovary to produce an egg. The egg will then travel to the uterus and if fertilized will stay in the uterus, but if not fertilized it will be shed and the woman will have a normal menstrual period. So, what happened in Pcos? Brain does not produce GnRH in normal cycles and causes LH level to rise, FSH level drop. So LH causes ovary to produce more testosterone and ovary is unable to produce an egg. So the primary abnormalities in Pcos is the abnormal release of the GnRH, as I mentioned earlier. So, instead of being released in regular cyclic manner, it is released rapidly throughout the day. This disrupts the release of the LH and FSH in a way the LH is increased but FSH is decreased into the peripheral circulation. In response to this, the ovary makes more male hormone testosterone or androgens and ovulation is inhibited. Next, clinical feature of Pcos. The patient with Pcos can be seen in generation of families, suggesting an autosomal mode of inheritance in such cases. However, no single gene has been consistently linked to this disorder, but most common endocrinopathy in reproductive age women affecting from 2% to 20% of this disease. But we can see the patient with Pcos like hirsutism, acne, hair loss, infertility, pelvic pain, irregular period, overweight, and the increasing in testosterone level. For diagnosis is established by histopathologic examination of surgically resected ovary in most cases. So, in clinical presentation, diagnosis in history, ovarian cancer can be asymptomatic until an advanced stage. The symptoms may include bloating or abdominal distension, loss of appetite, urinary agency or frequency, and pelvic or abdominal pain. For physical examination of diagnosis, abdominal or pelvic bimanual examination commonly identifies an adnexal mass. A site may be detected in a small proportion of patients and rarely inguinal lymph nodes may be palpable. So this is diagnosis procedure which have primary diagnostic tools. Diagnosis may be suspected based on presenting symptoms or discovery of an adnexal mass on pelvic examination or imaging. The diagnosis is confirmed by histopathologic examination of surgical specimen. Surgical removal of the complete ovary or ovaries rather than tissue biopsy is recommended to determine whether ovarian cancer is present. If malignancy is suspected, aspiration biopsy of an ovarian mass is contraindicated because of the risk of peritoneal contamination. Histopathology analysis of surgical specimen confirms diagnosis and assigns the histologic subtype and grade. Histology examination demonstrates increased thickness of cortical and subcortical stroma, thickened and collagenized tunica, increased number of developing and atretic follicles, and multiple cystic follicles 1 to 2 mm with theca lutein hyperplasia. A normal number of primordial follicle will be present. A case subset of patients shows stromal hyperplasia and hypertrichosis. Okay, so this is a case where the patient have Pcos. So in the figure 1 is the gross examination of ovaries from a patient with Pcos, with showing bluish cysts under the cortex, and the figure 2 is a section of ovaries demonstrating feature of Pcos, the increased number of subcortical cystic follicles. Okay, next, this is histopathology examination, and as we can see here, in figure 3 is a whole mouth section of Pcos ovary with cystic follicle, and in figure 4 we can see the cell is thickened, collagenized, and superficial cortex seen in Pcos. In figure 5, multiple luteinized cystic follicles seen in Pcos, and in figure 6 with higher magnification of cystic follicles in Pcos with expanded and luteinized theca layer also shown here with the black arrow. And lastly, in figure 7, multiple atretic follicles are common in Pcos sample. Type of treatment depends on a number of factors. The treatment may also depend on whether the patient wants to become pregnant in the future. If patient plans to become pregnant, the treatment may include a change in diet and activity, medication to cause ovulation. And if the patient do not plan to become pregnant, the treatment may include birth control pills, diabetes medication, a change in diet and activity, medication to treat other symptoms. But the most common therapy used to induce ovulation is clomipene, which has a success rate in achieving pregnancy of over 80%, and other manifestations are managed by weight loss, reducing hyperinsulinemia, and suppressing endometrial hyperplasia, which is oral contraceptive medication. So that's all from us. Thank you.